Hi, welcome to Proving Cures. I am your host, Sarah McLeod. I'm a medical writer and clinical researcher. Thanks for tuning in. Today is Thursday, October 24th, 2024. And this video is actually going to be dedicated to my sharing information about a clinical study that dives into a novel device that actually monitors breathing frequency in patients with muscular dystrophy. The title of the study is A Wearable Device for Breathing Frequency Monitoring, a pilot study on patients with muscular dystrophy. It was published fairly recently, September 18th, 2020, in a medical journal called Sensors. Okay. Now, the reason why this is so important and pivotal in the development of care for persons with muscular dystrophy is that in severe forms of muscular dystrophy, such as Duchenne muscular dystrophy, respiratory failure is still the principal cause of death, followed by cardiomyopathy. Muscle weakness, ineffective coughing, and reduced ventilation often lead to pneumonia, atelectasis, and respiratory insufficiency during both sleep and awake states. Pulmonary involvement is observed also in patients with some form of limb girdle muscular dystrophy and may occur early in the disease. While no therapy is available, new wide ranging and structured therapeutic approaches with increased attention to respiratory care do help improve muscular dystrophy patients' quality of life and life expectancy. Periodic measurement of respiratory function and respiratory muscle strength allow clinicians to predict when to introduce assisted coughing and assisted ventilation techniques. Recommended respiratory evaluation includes measurement of oxyhemoglobin saturation, spirometric parameters, maximum inspiratory and expiratory pressures, and peak cough flow once or twice per year. These patients need a careful respiratory assessment and periodic follow-up visits to monitor the progression of their disease. Nevertheless, the optimal frequency of follow-up is unknown. In fact, most patients with muscular dystrophy don't realize that they've lost respiratory muscle strength and cough effectiveness until a respiratory viral infection leads to pneumonia. For these reasons, continuous monitoring of respiratory activity and breathing pattern between consecutive follow-up visits could provide additional understanding about disease progression, in addition to traditional intermittent cardiopulmonary evaluations, allowing for prompt clinical intervention and anticipation of respiratory dysfunction. Moreover, the identification of early markers of respiratory dysfunction indices may also support the creation of personalized plans of sequential follow up, helping to ameliorate the quality of life of dystrophic patients. Continuous measurement of respiratory rate can be achieved by non intrusive wearable devices, which is amazing. This consists of deriving a respiratory related signal by detecting the motion of the thoraco-abdominal surface by inductive, resistive, or capacitive sensors. So let me explain a bit more about the device itself. The device that is studied in this paper is a wearable, unobtrusive, inertial sensor based device for long term breathing pattern monitoring, including during daily life activities. It consists of three inertial measurement units, a three axis accelerometer, a three axis gyroscope, and a three axis magnetometer, positioned on the patient's abdomen and thorax. In Figure C, you can see it positioned um, from a frontal view in a seated position. And it is also showed there to be positioned on a body area integral with the thorax but not affected by respiratory movements. The peripheral units, placed on thorax and abdomen, are used to record orientation changes during respiratory movements. The third unit is a central reference unit that receives data from the other two units. The information is then saved on an SD card and communicates via Bluetooth energy with a smartphone, tablet, or PC. The unit detects only non respiratory movement, representing not only a pure sense of noise that must be removed from the thoracic and abdominal signals, but also a pure source of additional information regarding the state of activity of the subject. The measurements provided by the IMU sensor are used by the microcontroller to calculate a quaternion, which represents orientations and rotations of the device units in 3 dimensions. So let's dive into a look at the participants and the study results. So 15 male neuromuscular subjects were enrolled, 13 with Duchenne muscular dystrophy, and 2 with limb girdle muscular dystrophy. All of the DMD subjects were wheelchair bound with an average loss of ambulation at around the age of 9 to 11 years old. One patient at the time of the test had poor ambulation ability. The limb girdle muscular dystrophic patients were wheelchair bound and lost ambulation capability at 48 and 42 years old, respectively. All DMD subjects, Duchenne muscular dystrophy subjects, presented with scoliosis with different degrees of severity, and 2 underwent posterior spinal fusion. 7 subjects had been previously treated with steroids for at least 2 years, and 4 were receiving steroid treatment at the time of evaluation. Subjects presenting with heart dysfunction, identified mainly with a left ventricle ejection fracture lower than 50%, were receiving beta blockers and ACE inhibitors, or both treatments at this time of the study. 11 subjects were using non invasive mechanical ventilation and began to use it on average at 22, give or take 6 years older or less of age. 2 patients also used non invasive mechanical ventilation during the daytime for a total amount of time of 18 to 22 hours per day. 3 patients also used non-invasive mechanical ventilation. Regarding respiratory muscle strength assessment, mean standard deviation, maximal inspiratory pressure, and maximal expiratory pressures were 35.57 centimeters of water and 35.29 centimeters of water, respectively. 6 of the 14 evaluated patients presented both MIP and MEP values of less than 20 centimeters of water. Mean peak cough flow had a standard deviation, an average standard deviation was 173.33, with 4 of the 10 evaluated patients presenting ineffective cough with peak cough flows of less than 160 liters per minute. The mean standard deviation of oxygen saturation at night was 95.81, with only 6 subjects presenting mild signs of nocturnal oxygen desaturations, spending more than 10% of the nighttime with oxygen saturations of less than 95%. And these results actually fit with the clinical picture characterized by restrictive lung pattern, respiratory muscle weakness, as shown by decreased maximal inspiratory pressures and maximal expiratory pressures, and ineffective cough. These are the results of the trial, but they actually demonstrate the effectiveness of the monitoring device. And with patient knowledge, um, it kind of like this information is meant basically, it can in fact arm patient caregivers with information to take to physicians to show that we can take the patient's care into our own hands as far as ongoing monitoring before the patient falls into a state of respiratory distress that can rapidly lead to fast deterioration. Um, without prior therapy, prior treatment. All right, so I hope you found this helpful in some way. Please leave comments of what you think about the information. Do please like, share, subscribe. Even if this information isn't necessarily helpful for you, I may have information in the future. Research is always ongoing that you might find helpful for either yourself or someone that you know. After this video, there's going to be a brief ad for my store. I am a fashion designer and I have a lot of like really cute things for working out, legging sets, jogger sets, that are designed more for the working professional. They're not like your drab everyday grays, blues, blacks. These outfits are things that can be paired with professional looks or dress down Friday looks or what have you. So please have a look. Also, you can tell me what you think about my designs in the comments section. I do ship worldwide. Thank you for your time. Until next time, bye bye.